Hello. Good day, everyone out there. Uh, I welcome you all to the next part 7 of endocrine physiology. So, if my audio is clear, my video settings are clear, if you are able to follow it properly, then kindly follow it. Let us begin our discussion. In this discussion, part 7 endocrine physiology, if you remember my last class, I was discussing about the hormones secreted by the pancreas, the alpha cell, the beta cells, and the delta cells of the pancreas, which are secreting insulin, glucagon, and various other hormones. We also discussed how this insulin metabolizes the carbohydrates, proteins, and fats. We also discussed how glucagon metabolizes the carbohydrates, proteins, and fats. In my first class of endocrine physiology, I told you how to differentiate the hormones, what are the differences between the different types of hormones, that is the lipid soluble hormones and the water soluble hormones, what are the important differences. That differences topic, again you go back and read that topic, because that is going to help us in understanding the various concepts on the nuclear receptors and the cell membrane receptors, so that we understand the glucose utilization, the entry of glucose into the cell, the entry of insulin into the cell, and various other mechanisms or pathways that begin after entry of glucose or insulin into the cell. So all these factors I already discussed. I just wanted to give you a reminder. In this chapter of part 7, actually our discussion is based on the calcium metabolism, understanding vitamin D, parathormone, and calcitonin. But to continue few small topics, clinical aspects of my last class, insulin, glucagon, and pancreas related hormones, few clinical aspects we need to understand, so that our understanding becomes more consolidated, and clinically also, if you are able to correlate our topics, that will be the complete understanding of physiology, right? So the most important aspect is, whenever a patient, say suppose he presents with hyperglycemia, the topic is very very big, but I want to make it short in terms of physiology. When I'll be reading the same topic in medicine, I'll be elaborating this topic. So say suppose a person presents with hyperglycemia, polyuria, that is multiple episodes of urination, or many times he is going for passing the urine, polyuria. And polydipsia, what is polydipsia? Dipsia means thirst. So polyuria, polydipsia, increased thirst, hyperglycemia. This person is actually diagnosed as clinical diagnosis of diabetes mellitus. And you will have to prove it biochemically by doing certain tests that I'll discuss in medicine chapter. But please remember, in diabetes mellitus, hyperglycemia, polyuria, polydipsia, that is a presentation. Any two of these can be present out of these three symptoms, but usually we see all the three symptoms to be present. Patient may have recent onset of blurred vision because of diabetic retinopathy. Patient may have mental confusion, weakness, lethargy immediately after having food. Patient will have increased sleep tendency, lethargy, and abnormal abnormal peripheral sensations, or patient will have abnormalities of tingling, numbness of hands and feet. All these we'll discuss in diabetes mellitus main chapter. But why does this occur? It is because of the problem with the insulin secretion and glucose utilization. Problem with the insulin secretion and glucose utilization. In few instances, insulin is not at all present. That is deficiency of insulin. In few instances, insulin is present, but the demand is so much high that we are unable to meet the demand. That is called as insulin resistance. All right. So all these are factors that lead to diabetes mellitus. There are two types of diabetes mellitus. Type 2 diabetes is the most common. Type 2 diabetes is the most common. Type 2 diabetes mellitus is the most common type. So here you see 90 to 95% of the patients presenting with type 2 diabetes mellitus. Usually the patient is obese. Usually the patient is adult, that is middle age or slightly older, not always older, but younger adult patients are also developing diabetes these days because of various lifestyle changes. We'll discuss that. So this is characterized by diabetes. Type 2 diabetes is characterized by insulin resistance. Then type 2 diabetes is also characterized by decreased insulin secretion from the pancreas. Secretion from the pancreas, or increased glucose output from the liver. All right. These are all the important characteristic pathologic degrees, or what we can say the underlying mechanisms for type 2 diabetes mellitus. Underlying mechanisms for type 2 diabetes mellitus. So when you check the plasma glucose, it is very high. Fasting blood sugar more than 125, 124 or 125 is considered as type 2 diabetes mellitus. Or postprandial blood sugars more than 160, then random blood sugar more than 200 at any time, HbA1c greater than 6.5. So all these points I'll discuss in clinical medicine. But in physiology, what is important? What are the insulin levels here? Please remember, insulin level may be high, may be normal, or may be low. This is very, very important. In type 2 diabetes, insulin level may be high or normal or low. The serum insulin levels are either higher or normal or low. Obviously, the plasma glucose is increased. Then patient with exercise and diet, he can get back to normal in mild cases. In mild cases, he can get back to normal whenever patient has got good diet and exercise. In mild cases, blood glucose levels decrease to some extent. Sometimes people may present with ketoacidosis or ketosis may be present, slightly rare, but definitely it is seen. The counter-regulatory hormones are very much increased. The counter-regulatory hormones like glucagon, epinephrine, in my last class I told you, glucagon, epinephrine, cortisol, all these hormones are very much increased. In case of non-obese persons, suppose type 2 diabetes occurs in a non-obese person, then you should think about certain genetic disorders of insulin deficiency more than insulin resistance. In obese people, insulin resistance is more common than insulin deficiency. All right. All these are important factors of type 2 diabetes mellitus. Let us now discuss the type 1 diabetes mellitus. Type 1 diabetes mellitus is rare when you compare to type 2 diabetes. It is usually seen in lean individuals. Person is lean and very young, age group. That is a rule. All right. But usually, slightly older, young, or young adult people also, we have seen certain cases. Here, the basic mechanism is absence of insulin production because of autoimmune destruction of beta cells. Autoimmune beta cell destruction. So that results in insulin deficiency. Variable degrees of insulin deficiency. Sometimes insulin is completely absent. Hence, it is an insulin-dependent diabetes mellitus. We cannot treat this disease with drugs which like sulfonylureas and all. There are 3 target tissues of insulin. Please remember: liver, the skeletal muscle, and the adipose tissue. These 3 target tissues of insulin. If insulin is absent, glucose cannot enter these 3 areas: liver, the skeletal muscle, and the adipose tissue. The glucose, amino acids, fatty acids, all the insulin metabolism fails. Thus, what will happen? Glucose, if it is unable to enter into the liver, unable to enter into the lungs, skeletal muscle, unable to enter into the adipose tissue, what will happen? It will start circulating in the blood. Once the glucose starts circulating in the blood, plasma levels of glucose are high, is it not? That will cause adverse effects on the blood, on the nerves, on the various other parts of our body, resulting in various complications of diabetes. Right? There is one more syndrome. Now, these days it is very, very common in young people. That is called as syndrome X or metabolic syndrome. Syndrome X or metabolic syndrome. In case of metabolic syndrome, what happens is there is increased blood pressure, increased blood glucose, that is patient develops diabetes mellitus. Patient develops elevated blood glucose, hypertension. Patient has central obesity. More importantly, patient has got dyslipidemia or hyperlipidemia. Here, patient has all lipid levels are high, LDL, total cholesterol, but there is decrease in protective cholesterol, that is the protective lipid, that is the HDL, low HDL values. This HDL is protective against atherosclerosis. So this person will develop atherosclerosis. This person with syndrome X may have prothrombotic and pro-inflammatory cytokines, prothrombotic and pro-inflammatory factors. Pro-inflammatory, pro-thrombotic state, so that this person develops myocardial infarction and stroke commonly. Myocardial infarction and stroke. And this person is prone for various other complications of diabetes, complications of hypertension and hyperlipidemia. All right. Now, these are basically because of improper lifestyle and consuming more carbohydrates and carbonated water and chemical or what do you say, fast food or processed food, highly processed food, and lack of exercise, right? So we'll discuss all these management investigations and all when I'll be discussing medicine. I'm just talking this because we have already dealt with the effects of insulin and glucagon. So to summarize, what will happen if there is insulin deficiency in individuals? Insulin deficient state, what will happen is basically there is improper metabolism of carbohydrates, so improper metabolism of carbohydrates, amino acids or proteins and fats, to be precise fatty acids. So in case of carbohydrate, what will happen? There is increased blood glucose levels, there is increased breakdown of glycogen, increased glycogen breakdown, and decreased peripheral utilization of glucose. Decreased peripheral utilization of glucose. In case of proteins, what will happen? There is increased breakdown of protein, increased breakdown, increased catabolism, increased blood ureagenesis, increased gluconeogenesis, and decreased protein synthesis. In case of fatty acids, fatty acid metabolism, what will happen? There is increased breakdown of triglycerides, there is increased level, the defective utilization of fatty acids resulting in increased circulation of fatty acids, circulating fatty acids. There is decreased fatty acid synthesis, decreased triglyceride synthesis, and increase in the ketone bodies. It's a very, very important point. Increased ketone bodies, right, resulting in diabetic ketoacidosis. Is there any effect of this insulin on renal system? Yes. What will happen is there is failure of reabsorption of filtered glucose in the proximal tubule, and this prevents the water reabsorption, this prevents the electrolyte reabsorption, resulting in disorders of sodium ion concentration, disorders of potassium ion concentration. We'll discuss that. So what will happen to potassium ion concentration? See, usually what happens, H plus moves intracellularly. H plus and potassium they move in one direction. All right, I already told you. H plus and potassium move in one direction. So what will happen is, in case of absence of insulin, the pumping effect of potassium into the cells is decreased. Because of this, what will happen? More and more potassium is accumulating in the serum. It is not entering into the cell. It is more and more potassium is staying back like glucose into the blood, resulting in hyperkalemia. So because of deficiency of insulin, hyperkalemia is a consequence. But plasma potassium is when you go and check it, it may be normal because of renal compensatory renal loss, because of the renal loss or renal excretion of potassium through the collecting duct or some other part. The body stores of the potassium are reduced. See, though the levels of potassium are increased in serum, but what will happen? More and more loss is occurring, and patient will develop what is known as consequently in a period of time, patient will develop after insulin resistance. Patient may develop hypokalemia. So initially hyperkalemia, later on, long-standing after insulin replacement, patient develops hypokalemia. All right. The effect of deficiency insulin in the on the sodium concentration. What is the sodium concentration? If you see the effective osmolarity, the effective osmolarity is calculated by the formula 2 times sodium concentration in milliequivalents per liter plus glucose in milligrams per deciliter divided by 18. This formula helps us in understanding the sodium balance. So what will happen if patient has polyuria? In diabetes, patient has polyuria. So polyuria, it decreases the total sodium. But with dehydration, the sodium levels are kept close to normal, because see what happens is in a hyperosmolar state, because of hyperglycemia, if glucose levels are increasing, osmolarity is increased. Is it not? In diabetes, glucose levels are more, so osmolarity, so 2 times the sodium concentration plus glucose. Now this formula sometimes, you know, it may mislead in case of diabetes mellitus, this formula may sometimes mislead because of increased glucose concentration. But overall what happens is, because of polyuria, there is a decrease in sodium concentration, slight decrease in the sodium concentration. Even though the sodium concentration is decreasing, the serum osmolarity is high. That is because of glucose, increase in glucose, right? This is what you will have to understand. Few patients develop what is known as hyperosmolar coma, especially in type 2 diabetes mellitus. Hyperosmolar coma. Now this hyperosmolar coma is because of whenever hyperglycemia occurs, this hyperglycemia shifts the fluid from intracellular compartment to the extracellular compartment. Because of hyperglycemia, the fluid shifts from intracellular compartment to extracellular compartment. And then what will happen? Initially, there is shift of fluid from ICF, intracellular compartment, to ECF. In the ECF, what's happening? Patient is developing polyuria. Because of polyuria, again, the volume from the extracellular space is decreased. And this leads to decreased renal plasma flow. And overall, decreased renal plasma flow is decreased. That is, the renal plasma flow is decreased. If renal plasma flow is decreased, this tends to reduce the glucose excretion. Excretion of glucose is reduced. This tends to reduce the glucose. So all these effects combined with the counter-regulatory hormone effects, what will happen is the plasma glucose, what will happen to plasma glucose? Further increases, is it not? Because excretion is decreasing, the plasma glucose is further increasing. It is further causing damage to the glucose related damage in the intracellular compartment. In the serum, intravascular compartment. So what will happen? There is severe loss of intracellular fluid first, then there is loss of extracellular fluid, then there is decrease in sodium, the glucose excretion, and increased plasma glucose. All these will combine together and result in hyperosmolar coma, especially in the brain. What will happen in the brain is, now in the skeletal muscle and other tissues of our body, if intracellular fluid is reduced, it will not have much effect as compared to the effect on the brain. So in the brain, if there is slightest decrease in the intracellular fluid is reduced, patient will develop coma. Patient will develop confusion, delirium, sometimes seizures also, hyperglycemic seizures. So in case of type 2 diabetes, usually this is the scenario. In case of type 2 diabetes, high plasma glucose, very, very high plasma glucose is seen. And this results in greater states of dehydration and greater incidence of coma. All right. We have, similar to this mechanism, we have another mechanism that is commonly seen in type 1 diabetes people, that is diabetic ketoacidosis. What is diabetic ketoacidosis? Quickly we'll try to understand. So with the insulin deficiency, what happens is there is increased fatty acid synthesis. Increased fatty acid synthesis. Now this increased fatty acid synthesis in the liver, what will happen is preferentially it is converted into ketone bodies. What are the examples of ketone bodies in biochemistry? I'll teach you. The acetone, acetoacetic acid, the beta hydroxybutyric acid. So acetone, acetoacetic acid and beta hydroxybutyric acid are very much produced. Because of this, what happens? Acidic component is produced. So what happened to the blood pH? The blood pH decreases. What will happen to the bicarbonate concentration? If H plus is increasing, the bicarbonate concentration decreases. Bicarbonate decreases, blood pH decreases. This leads to metabolic acidosis. Are you able to follow this? In diabetic ketoacidosis. And because of this, what happens is our body tries to compensate by respiration, increased respiratory rate, so that carbon dioxide is exhaled out. Because of this respiratory compensation, what will happen is this person develops air hunger type of breathing called as Kussmaul's breathing. Air hunger type of breathing called as Kussmaul's breathing. Kussmaul's breathing is a deep inspiratory drive. Deep and rapid inspiration with pH less than 7.2, with bicarbonate low. Your diagnosis is diabetic ketoacidosis. Now if you check the urine shows presence of ketone bodies are present in the urine. Can be easily detected in the urine. Because of severe acidosis, patient will develop dehydration. And there is decrease in the sodium concentration because of polyuria. There is decrease in the potassium concentration because of deficiency of insulin. All right. So in the treatment of diabetic ketoacidosis, you will have to address these problems. You will have to correct the acidosis, you will have to correct the dehydration, you will have to correct the insulin deficiency, you will have to correct the sodium and potassium loss. All right, all these factors should be. So in the treatment of diabetic ketoacidosis, the most important step to treat diabetic ketoacidosis is to correct dehydration. So first you need to correct the dehydration. Dehydration should be corrected first. Along with that, you will have to provide insulin to the patient. Next step, IV insulin. And subcutaneous insulin is not fully absorbed, so you'll have to give intravenous insulin first. And patient develops hyponatremia. So for every 100 points decrease in the glucose, there is 1.6 decrease in the sodium. So 100 milligrams per deciliter decrease in glucose, there is 1.6, around close to 1.6 milliequivalents per liter decrease in the sodium. We all know that hyponatremia has a direct effect on the brain, resulting in confusion state. All right. So you will have to elevate the glucose. So for every 100 milligrams per deciliter increase in glucose, there is sodium loss occurs. So when hyponatremia is present, along with hyperglycemia, the management is correction of glucose level itself. All right. When glucose comes back to normal, the sodium automatically it gets corrected. This point you will have to understand. For every 100-point increase in blood glucose, I'm sorry, it was increase, not decrease, as I told you just now previously. So every increase in the blood glucose, there is a decrease in 1.6 milliequivalents per liter decrease in the sodium. So once you correct this, definitely the hyponatremia comes back to normal. You need not, correct the sodium level separately by infusion of sodium. All right. Apart from this, so these are all the clinical aspects of insulin and glucagon. Apart from this, there are certain pancreas endocrine tumors like insulinoma, which is the most common islet cell tumor. Few points about insulinoma, let us try to understand. Insulinoma, this is the most common type of tumor of the islet cells. All right, because obviously the islet cell beta cells are very high in number, so obviously this is the most common tumor within the pancreas, and increased secretion of insulin within the pancreas. These tumors will have increased secretion of insulin. They are associated with multiple endocrine neoplasia 1, men 1. I already discussed multiple endocrine neoplasia in my last class. So the insulin that is measured to determine the insulin mediated versus non-insulin mediated hypoglycemia, patient usually develops hypoglycemia because of increased insulin. Increased insulin. Here what happens is, we all know that insulin, initially in the beta cells we have got pre-proinsulin, then proinsulin. I already told you in my last class, pre-proinsulin, then this gets converted to proinsulin in the vesicles, then it is released and it is getting converted to C-peptide and insulin proper, the A and B chain of the insulin. All right. So what will happen is, insulin mediated hypoglycemia, what will happen is, the levels of C-peptide and the levels of insulin are equal. Serum levels, if you see, both are elevated. If both are elevated, this is insulinoma. If suppose only insulin is elevated, C-peptide is normal or low, it means exogenous insulin has caused hypoglycemia. So a person with hypoglycemia comes to your hospital, you check for both the C-peptide levels and insulin levels. If both are elevated, this person may have hyperinsulin secretion because of insulinoma. If suppose C-peptide levels are normal or low, but only insulin levels are high, then this person may have decreased exogenous. Somebody has injected him insulin to cause hypoglycemia, or he himself injected insulin to cause hypoglycemia, and you will have to investigate accordingly, treat accordingly. There are other tumors of the endocrine system like gastrinoma, glucagonoma, somatostatinoma, VIPomas. All these are neuroendocrine tumors, and we localize it and we surgically remove it. So like insulinoma is a beta cell tumor, glucagonoma is a alpha cell hypersecretion, alpha cell tumor. So patient may develop diabetes, patient may develop hyperglycemia. You will have to remove it surgically, right? So these are all important clinical aspects of the insulin and glucagon. Let us come to the important part 7 of endocrine physiology proper. Part 7 of endocrine physiology proper. That is hormonal control of calcium and phosphate. Calcium phosphate regulation. Calcium and phosphate hormonal regulation. To understand this, first we need to understand what are the important effects of calcium and phosphate onto the body. Where is calcium stored, where is calcium absorbed, and where is calcium absorption stimulated? What are the hormones which are controlling this? Like first we'll discuss calcitonin, parathormone, and then the vitamin D, and we'll then in the end we'll discuss the diseases related to calcium and phosphate metabolism. This chapter is also discussed in biochemistry later on, but I will discuss the same thing here also. So you need to understand that 99% of the calcium is, we'll first discuss the calcium metabolism. So 90 to 95% of the calcium is concentrated in the bone. We have got 90% of the calcium in the 90 to 95% of the calcium is of total calcium is present in the bone. In the bone, the calcium is in the form of hydroxyapatite. Calcium hydroxyapatite is a chemical name, complex name. Hydroxyapatite crystals or salt, calcium phosphate. So whenever body needs calcium, what will happen is calcium comes out of the bone, it enters into the blood, it causes various metabolic events like neuronal stimulation, like excitation of the muscle contraction complex, like various other hormonal release, enzyme release, and various other metabolic pathways. And then once its work is done, it goes back to the bone. So the calcium from bone, it enters the interstitial fluid. From the interstitial fluid, it enters the plasma. From the interstitial fluid, either it goes to the plasma or the intracellular fluid and performs various activities, and then comes back to the bone. Comes back to the bone. All right. So the coming back pathway is also same. From the plasma, from the ICF, it comes back to the interstitial fluid, and from there into the bone. All right. This is how is the calcium. So you may wonder, where is the calcium? Second best area of storage of calcium. Usually in the intracellular fluid, 1% of the calcium is present in the intracellular fluid. 0.1% stays in the interstitial fluid. Less than 0.5% in the plasma. The rest of all the calcium is stored in the bone, and whenever we want, we can extract this calcium from the bone. So if you see the plasma calcium, it represents 50% of the ionized free calcium. 50% of the plasma calcium is free. 40% is attached to the proteins, protein bound. I'm talking about the plasma calcium, and 10% of it is associated with the anions, that is the phosphate ion or the citrate ion, calcium citrate, calcium phosphate, something like that. It is the free calcium which is responsible for all the metabolic actions. Or in my first class of hormone physiology, I told you, it is a free hormone which is responsible for all the physiologically, metabolically active mechanisms. All right. And this is what is the free calcium is regulated. Whenever I see regulation, that is entry into the cell, exit from the cell, entry into the plasma, exit from the plasma, entry into the interstitial fluid, exit from the interstitial fluid, all these we are talking about free calcium only. Whenever a person undergoes hyperventilation, it decreases, and acidosis, it increases the free plasma calcium. So please remember, hyperventilation decreases free calcium, and acidosis increases free calcium. All right. Now let us try to understand the relationship between calcium and phosphate. So bone is a very complex precipitate of calcium and phosphate, to which the bicarbonate ions, the various other ions are added to make a hydroxyapatite crystals. These hydroxyapatite crystals are stored in the bone in the form of osteoid matrix. Bone matrix, we call it osteoid matrix. Osteoid matrix. Now, which the calcium and phosphate which are stored here, the storage exactly depends on the product of their concentration rather than individual. That is, calcium and phosphate together they are stored. They are not stored individually. So we need to understand that product of calcium concentration, product of phosphate concentration, this is the determinant of bone deposition. This is the determinant of bone deposition. What does that mean? It means that the consolidation or solid form of bone, the bone is laid down based on the solubility product, whether calcium and phosphate can intermingle with each other or not, can be soluble or not. Under normal conditions, what happens? The product of calcium and the product of calcium and the phosphate, this is termed as solubility product. Solubility product, to understand, the under normal conditions. Whenever there is increase in the intracellular fluid concentration of calcium, or whenever there is increase in the phosphate concentration, increase in the serum calcium, or increase in the phosphate calcium, serum phosphate levels, what will happen? This increases the bone deposition. The process, we call it mineralization. We say that mineralization of bone has increased, and obviously vice versa will happen. All right. Sometimes what happens, there is malignancies, malignant increase in the concentration of calcium, malignant increase in the calcium phosphate because of renal disease, chronic kidney disease, or because of muscle breakdown, rhabdomyolysis. These conditions, they increase the mineralization so that the serum calcium comes down. All right, the serum calcium comes down. So whenever the plasma phosphate rises, it promotes mineralization. Whenever the plasma calcium rises, it promotes mineralization. All right, it means what? More and more calcium and phosphate are going and depositing in the bone. What will happen to the serum concentration? Serum concentration comes down. When I say increase mineralization, automatically you should understand that serum calcium phosphate levels are coming down. Serum calcium phosphate levels are coming down. Now let us try to understand another scenario wherein the product of calcium, say suppose the product of calcium and phosphate are low. If it is low, solubility is less, or if it is low, this results in what is known as bone resorption. See, this concept is very, very important to understand the physiology of osteoclast and osteoblast. I'll be discussing bone remodeling shortly from now. But this concept, if you don't understand, you will not understand the next step. So please remember this point. Whenever the calcium and phosphate solubility, they are unable to intermingle with each other, the soluble ratio or solubility product is less. So body thinks that calcium and phosphate levels are low and resorption starts. Resorption is breakdown. Resorption is opposite of mineralization. Mineralization means deposition. Resorption means cutting down or breaking down. So whenever there is decrease in the interstitial fluid concentration of calcium or interstitial fluid concentration of phosphate, this promotes the resorption. You can also call it demineralization. So you can also call it demineralization. All right. So what happens is, whenever, say suppose for example, plasma phosphate levels are low. Say suppose in the blood, plasma phosphate levels are low. calcium levels are low. This promotes the demineralization, exactly opposite to bone deposition. If plasma phosphate levels are high, it promotes mineralization, exactly opposite. Plasma phosphate levels are low, it promotes demineralization. So who is determining this mineralization and demineralization? It is the free calcium actually. If you understand it closely, free calcium is the one which is actually regulated so precisely. Free calcium regulation is occurring so precise. 24 hours our bone is working. We think that bone is not working. Bone is only bone. What is the role of bone? If I ask you, you may say that, sir, it gives strength to the body. Because of bone I am able to stand. Because of long bones I am able to perform activities. I am able to sit, I am able to stand. But there is 24 hours throughout the day. There are activities going on at the cellular level in your bone. Every day what happens is deposition, mineralization. Every second of your life, bone is deciding whether to release calcium phosphate or to deposit calcium phosphate. This is happening throughout the day. If there is any mismatch in this deposition and resorption, what will happen? Patient will develop osteoporosis, all right, and various other clinical disorders. So please remember that the free calcium, the hormonal control of the free calcium is via the parath hormone and the vitamin D. Vitamin D and parath hormone, they control the free calcium. How we'll discuss shortly from now. But before this, we'll try to understand the concept of bone remodeling. Let us try to understand the concept of bone remodeling. Bone remodeling. All right. So what's happening in the bone remodeling? Let us try to understand. So we have got three important cells. We have got osteoblasts, osteoclast, and osteocyte. Osteoblast, osteoclast, and osteocytes. All right. The complex interplay between these three helps in remodeling of the bone. Bone undergoes continuous process of remodeling throughout your life, throughout the month, throughout the week, throughout the day. Every day, 24 hours, it is undergoing remodeling. How this is occurring? It is occurring because of the turnover. That is the turnover which is faster in younger individuals, slightly slower in older individuals. There is an interplay between bone building cells and bone breaking cells. So what is this bone building cell and bone breaking cell? Bone building cell, we are calling it as osteoblast. Bone breaking cells, we call it osteoclast. All right. So osteoblast will cause bone deposition. Osteoclast will cause bone resorption or bone breakdown. Osteoblast, they cause bone resorption, bone deposition. Osteoclast cause bone resorption. How? Let us try to understand. Osteoblast they secrete two proteins. These two proteins are important in bringing out the activity of osteoblast spike, that is the bone deposition. How? The two proteins are, one is rank L protein, RANK, rank ligand we call it, rank ligand. Another is OPG. You'll have to remember this. You will have to remember always this point. Two important proteins are responsible for the activity of osteoblast. We have got rank ligand, rank L protein, which helps in differentiation of osteoblast to osteoclast, and the osteoclast, which have rank receptors, it increases the osteoclastic activity. All right. Whereas OPG is osteoproteogerin. Rank L stands for receptor activator of nuclear kappa B ligand. Receptor activator of nuclear kappa B ligand. Receptor activator of nuclear kappa B ligand. OPG stands for osteoproteogerin. So what is the activity of rank L? The rank L stimulates or activates osteoclast. Yes, you have heard it right. Osteoblast has two proteins. One is rank L, one is OPG. The rank L, the overall effect is it activates osteoclast. Whereas OPG, it inhibits the osteoclastic activity. Inhibits the osteoclastic activity. We call it decoy. Decoy of, that is, it is opposite of rank L, rank ligand. It is called as decoy of rank L. That is, it inhibits the osteoclast activity. It inhibits the osteoclast activity. How is this occurring? See, what happens is, there are rank receptors present on the osteoclast. So an active osteoclast, to activate osteoclast, there is a rank receptor on which rank will go and sit, and it activates. OPG prevents this binding of rank to the osteoclastic receptor. Alright? Hence it reduces the rank ligand activity. Please remember that whenever parath hormone, vitamin D, active form of vitamin D, estrogen and various other hormones, they are activated. These hormones will influence the bone remodeling. How is this bone remodeling influenced? How is this bone remodeling influenced? It induces the synthesis of osteoproteogerin. It reduces the secretion of cytokines, that is the cytokines which can differentiate the active osteoclast, and they stimulate conversion of mature osteocytes. Osteocytes are cells which are dormant cells which can become osteoblasts. Alright, and the inhibition of cytokines or promotion of cytokines is brought about by the activity of rank ligand and OPG. Alright, there are certain hormones like glucocorticoids which increase the bone breakdown. There are certain hormones like vitamin D and estrogen which promote the bone deposition. Alright, promotion of bone deposition and breakdown of bone deposition are because of increase and decrease in the rank ligand and OPG synthesis. Alright, this is the basic mechanism by which the bone remodeling occurs. For example, say suppose this is the bone. Alright, on the bone surface, say suppose we have got, these are the osteoblast. Osteoblast. So because of positive effect of parath hormone or vitamin D, what will happen on the osteoblast? Say suppose this is the osteoblast. Because of this, what happens is, there is a promotion of OPG. Simultaneously, this OPG will cause inhibition of rank ligand. Hence, the activity of osteoclast is decreased. There is reduced activity of the osteoclast. Say suppose this is the osteoclast. Alright. The osteoclast precursors. Alright. Now this osteoclast, whenever it comes Suppose because of glucocorticoids, what will happen because of glucocorticoid? The osteoclastic activity increased. Say suppose glucocorticoid, it stimulates the osteoclastic activity. It is stimulating the osteoclastic activity. Now this osteoclast will come and sit on the bone like this, and they start resorption. They start the resorption. All right. In this diagram, please try to remember that estrogen promotes the OPG. Estrogen promotes the OPG. Estrogen inhibits the cytokines which activate the osteoclast. So estrogen works by two mechanisms. One is by promoting the OPG. So estrogen is working here by promoting the OPG. Estrogen also inhibits the cytokines which promote the osteoclast activity. Glucocorticoid directly, it can stimulate the osteoclast activity, right? So please remember that the free calcium is maintained with the help of all these activities. Free calcium is maintained to the normal level. Whenever free calcium levels are low, osteoclast activity is increased. Whenever free calcium levels are high, the bone deposition, mineralization or osteoblast activity is increased. Now time has come, let us try to understand what is the action of various hormones like parathormone, calcitonin and vitamin D. Let us try to understand first the parathyroid hormone. Parathyroid hormone, also called as parathormone. Parathormone or PTH, parathyroid hormone. Let us try to understand the activity of these hormones. The parathyroid hormone action. The first is parathormone. It decreases the free calcium level. Whenever there is a decrease in free calcium level, that is a decrease in the serum calcium. Say suppose there is a decrease in the serum calcium. This stimulates the parathormone. Excuse me. This stimulates the parathormone secretion from the parathyroid gland. So what is the function of parathormone? Parathormone function is to increase calcium levels in the body. How does it increase? What is the mechanism by which we increase calcium level? By bone resorption or by bone deposition? By bone resorption. So parathormone promotes increase in the serum calcium by the following mechanisms. Parathormone increases the serum calcium by the following mechanism. First, it increases the reabsorption of calcium from the kidneys. Where does it act in the kidney? It acts on the distal tubules, distal convolutubules or distal tubules of the kidneys. It prevents the excretion and increases the reabsorption of calcium. We all know that calcium reabsorption is a very, very important function of distal convolute tubule of the kidney. I told you that distal convolute tubule of the kidney is involved in reabsorption of calcium. So here the parathormone is acting and it is increasing the reabsorption of the calcium. Second thing is it increases the phosphate reabsorption from the proximal tubule. From the proximal tubule of the kidneys, it is acting and increasing because proximal tubules maximum reabsorption occurs. 90% of the substrates are reabsorbed in the proximal convolute tubule. I already told you when I was teaching my kidney chapter, nephron chapter. Next is parathormone stimulates the activation of the vitamin D. So it activates vitamin D, which further increases the calcium levels in the blood. And most importantly, the fourth point of parathormone is very, very important. Most importantly, parathormone promotes bone resorption. All these four scenarios will increase the serum calcium and blood and phosphate in the blood. Serum calcium and phosphate in the blood. So I revise. Parathormone increases the calcium reabsorption in the kidney. Parathormone inhibits the phosphate reabsorption in the kidney. It increases the inhibition of phosphate reabsorption, or it promotes the excretion of phosphate. So just now I told you increases reabsorption. That is wrong. So increase calcium reabsorption in the kidneys. It decreases the phosphate reabsorption in the kidney, or promotes the excretion. I wanted to say promotes excretion of phosphate. It activates vitamin D, and it promotes the, what do you say, bone resorption. Bone resorption promotion is the most important effect of parathormone. How does it promote the bone resorption? Let us try to understand. So parathormone induced bone resorption is a very, very complex process. And what happens is the osteoblasts, they express receptors. So osteoblasts, they have receptors. Osteoblasts are the bone promote, the what do you say, the remodeling promoter, or the bone deposition promoter cells, is it not? Osteoblasts, they have got receptors for parathormone receptors, parathormone receptor proteins. Whenever parathormone binds to this receptor, it stimulates the release of rank ligand. What is the function of rank ligand? To activate osteoclast. To activate osteoclastic activity. Hence, the bone resorption starts. What is the end product of bone resorption? Increase in serum calcium. Increase in serum calcium, is it not? And increase in the phosphate calcium. Give me a 2 minutes break for azan. Welcome back. So I was discussing the activity of parathormone receptor, which whenever parathormone sits on this receptor, it stimulates the activity of rank ligand that causes activation of the osteoclast, that causes resorption of the bone resorption. All right. But one important point, please remember that in osteoporosis, a person suffering from osteoporosis, we give injections of parathormone. So injectable form of parathormone that we are giving as a treatment for osteoporosis actually promoting osteoblast and causing bone deposition. So this is a paradoxical role. Exact mechanism is not known, but its treatment in osteoporosis is approved by FDA, and injection parathormone can be given in severe forms of osteoporosis to cause bone deposition. The reason is some books it was explained that small pulsatile doses of parathormone actually cause beneficial effect by bone deposition. Small amount of like pulsatile injections of these parathormone will result in initial osteoclast activity, but later on it stimulates osteoblast activity in the long run and cause bone deposition. So it's exactly opposite to what we are expecting. One more important clinical aspect you need to remember is, in case of malignancies, what will happen is parathormone related protein, PTHRP, parathormone related protein in certain malignancies, there is a paracrine hormone, that is this PTHRP is secreted by the lungs, the breasts, and various other parts of our body like placenta. And whenever a tumor of these areas or whenever a cancer of these areas occurs, what will happen is there is excessive secretion of this parathormone resulting in malignant hypercalcemia. Malignant hypercalcemia, which may cause sometimes death because of overexpression of this parathormone related peptide or parathormone related protein or peptide, whatever it is. It has got it looks similar to parathormone, and it starts activating the osteoblast to release release rank ligand, which activates the osteoclastic activity. So how is parathormone regulated? I told you that whenever there is, if you go back to my first point of parathormone, I told you that whenever there is fall in the serum calcium levels, whenever there is fall in the serum calcium level means what? Who is detecting this serum calcium level? There are certain receptors of serum calcium, we call it calcium sensing receptors. These are small proteins, calcium sensing receptors. These proteins give a feedback to the parathyroid gland to sense the level of calcium in the body. The parathyroid cells have this receptor, calcium sensing receptor. Calcium sensing receptor, the levels of calcium are detected, and whenever the level of calcium is low, it stimulates parathormone. Whenever calcium levels are high, it decreases the parathormone. So there is a negative feedback of these cells. Most of these cells detect the intracellular free calcium levels, calcium levels, and any fall in the intracellular calcium level of parathyroid cells, this stimulates the parathormone release. All right, and this is related to magnesium levels also. How is it related to magnesium levels? We'll discuss in medicine. Hypomagnesemia will cause hypoparathyroidism. I'll discuss that. So increase in parathormone, you are calling it as hyperparathyroidism. Decrease in parathyroid hormone, we are calling it hypoparathyroidism. There are various types of hypoparathyroidism: primary, secondary, pseudo hypoparathyroidism, pseudo hypoparathyroidism. We'll all discuss that in the end of this chapter, right? So we were discussing the hormones which regulate the calcium and phosphate metabolism. The second hormone which regulates the calcium and phosphate metabolism is calcitonin. Calcitonin is a peptide hormone. Calcitonin is secreted by the parafollicular cells of the thyroid. Parafollicular cells of the thyroid gland. We also call it C cells of the thyroid gland. The parafollicular cells of the thyroid. What is the function? What is the action of calcitonin? Calcitonin it lowers the plasma calcium. It decreases the plasma calcium. What was the role of parathormone? To increase the plasma calcium. Here it decreases the plasma calcium, exactly opposite to parathormone activity. How? By decreasing the bone resorption, by increasing the activity of the by inhibiting the activity of the osteoclast. So by decreasing the osteoclastic activity. By decreasing the osteoclastic activity. Thus calcitonin, it decreases the bone resorption, is it not? So any condition in which bone resorption is increased, like osteoporosis, like malignant hypercalcemia, you can give calcitonin, you can increase the levels of calcitonin so that the calcium levels are coming down. Please remember, calcitonin is not a major controller of calcium metabolism in our body. If suppose by some mechanism you remove calcitonin from our body, it does not affect the calcium metabolism much, because we have various other mechanisms of control of calcium, lowering and improving the plasma calcium levels, like parathormone and vitamin D. So this is importance of calcium metabolism, and calcitonin, it has got a little effect, right? Next let us talk about the major controller of vitamin D, of calcium, that is the vitamin D. All right, what is the role of calcium D? How is it synthesized? How is it activated? And what is the action? Let us try to understand. So through the dietary intake, through the diet, we get vitamin D2 and vitamin D3. D2 and D3 are different forms of vitamin. Through the skin, we get what is known as 7-dehydrocholesterol, that is synthesized in the skin. Both of these are important in formation or of active form of vitamin. Both of these are inactive forms of vitamin D. Both of these are inactive forms of vitamin D. These are taken to the liver, where liver has an enzyme 25-hydroxylase. In the liver. So this converts the inactive form of vitamin D into 25-hydroxy vitamin D. This 25-hydroxy vitamin D is the main circulating form. If they ask you which is the major circulating form of vitamin D, major circulating form of vitamin D, if they ask you, it is 25-hydroxy vitamin D. This is a major, maximum concentration is this one, 25-hydroxy, 25-OH vitamin D. But the problem with this is it has got a low activity, very, very low clinical activity. This is taken to the kidney. 25-hydroxy vitamin D goes to the kidney. In the kidney, we have got 1-alpha-hydroxylase enzyme. 1-alpha-hydroxylase enzyme is present in the proximal convoluted tubule of the kidney. And this converts the 25-hydroxy vitamin D into 1,25-dihydroxy vitamin D. This is the active form of vitamin D. There is one more product formed, that is 24,25-dihydroxy vitamin D. This is also so 24,25-dihydroxy vitamin D. This is also a form of vitamin D, but with low activity. The most active form of vitamin D, is the 125 dihydroxy vitamin D, which is synthesized in the kidneys. Please remember this 1-alpha hydroxylase. This 1-alpha hydroxylase enzyme is the most important enzyme in the kidney, which is converting the partially active form of vitamin D into active form of vitamin D, so as to bring about changes in the calcium and phosphate metabolism. Activity is increased, so enzyme activity is controlled by parathormone. This enzyme activity is controlled by, just one second. Right. So activity of 1-alpha hydroxylase is controlled by the parathormone. Activity of 1-alpha hydroxylase is also controlled by low phosphate levels. Phosphate controls the activity. This is the most important point you have to remember. Whenever phosphate levels are low, the alpha hydroxylase activity is high. Parathormone also increases this 1-alpha hydroxylase activity. All right. The synthesis of active form of vitamin D. Active form of vitamin D, we call it calcitriol. The synthesis of calcitriol, it starts from the skin or gut, then goes to the liver, from there to the kidney. Now this mechanism you'll always have to remember in order. First skin or gut, then to the liver, then to the kidney. The relative number of molecules of each of these hydroxylated forms of vitamin D, the highest in concentration in circulation, if they ask you, it is 25 hydroxy vitamin D. But the active form, if they ask you, it is 125 dihydroxy vitamin D. And it is the UV light in the skin which converts the 7-dehydrocholesterol, UV light that converts the 7-dehydrocholesterol and it subsequent formation of vitamin D3. Hence the UV light, we ask the patients who have got deficiency of vitamin D to get exposed in the sunlight. Get exposed into the sunlight. The UV light in the sun helps in providing or activating the vitamin D3. Now let us try to understand what are the physiological effects or actions of calcitriol. Let us try to understand. Calcitriol, it increases the calcium absorption from the gut. Calcium absorption and phosphate absorption from the intestines. How does it promote? It promotes by formation of a binding protein called as Col binding. This binding protein present in the intestinal mucosa, it binds with the calcium and it helps in absorption of calcium. Because of this, what happens? The calcium levels, the calcium concentration and phosphate concentration in the blood, in the extracellular fluid increases. Whenever calcium and phosphate solubility increases, I told you, the product of this solubility, the calcium phosphate product, if you take the product of concentration of this in the extracellular fluid, it increases the solubility. If this increases the solubility product is increased, means what? It promotes bone deposition. I told you. Bone deposition also called as mineralization. So calcitriol promotes the mineralization. Calcitriol has a positive feedback on parathormone. It promotes parathormone action in the distal convoluted. In the distal convoluted, what happens? What is the function of important property of distal convoluted? To increase the calcium reabsorption from the distal convoluted. So parathormone is promoted by calcitriol. in the gut, calcitriol is acting for increased reabsorption of calcium and phosphate. So overall result is increase in the calcium and phosphate. This solubility product, if it is increased, it results in the promotion of bone deposition or mineralization. At abnormally high activity of calcitriol, sometimes calcitriol levels are very, very high, it increases bone resorption. So whenever the calcitriol levels, if they exceed the normal value, if they become abnormally high, so it self-checks itself by increasing the bone resorption. By increasing the bone resorption. Please remember, as the osteoblast have receptors of parathormone, osteoblast, the nuclear membrane of the osteoblast have got receptors for calcitriol, because calcitriol is a lipid soluble hormone, is it not? So if this is the osteoblast and this is the nucleus of the osteoblast, so we have got receptors of parathormone outside because it's a protein hormone. Receptors of vitamin D, calcitriol, D3 receptors are present on the nucleus. D3 receptors are present on the nuclear. These are nuclear receptors. Receptors of calcitriol are the nuclear membrane receptors, and through the communication from the osteoblast, the activity of osteoclast is carried out by rank ligand. We all know the mechanism, and calcitriol requires presence of parathormone to cause bone resorption. For this activity that is abnormally high, it acts via the parathormone activity, because it is promoting the parathormone activity, we all know. In high levels, the promotion of parathormone activity is very much enhanced. So what will happen whenever there is fall in the plasma calcium level? It promotes parathormone. Whenever there is fall in the plasma calcium level, so it's let us try to finalize. Now we have understood parathormone, calcitonin and vitamin D. Let us try to finalize our understanding now. Whenever there is fall in the calcium levels in the blood, this promotes parathormone. Parathormone, it activates 1-alpha hydroxylase enzyme in the kidneys so that vitamin D is secreted. This vitamin D3 increases the reabsorption of calcium from the gut, reabsorption of the calcium from the distal convoluted tubule, and also it promotes the parathormone activity. Parathormone also causes calcium resorption by increasing the osteoclast activity. Parathormone mobilizes calcium from the bone. Parathormone, it also acts on the proximal convoluted tubule, decreases the phosphate reabsorption. Any decrease in the plasma phosphate, again, it stimulates, it results in decrease in the plasma calcium. Acidosis, it stimulates increase in the plasma calcium. Hyperventilation, it stimulates the plasma calcium. All right. All these points we have understood. Estrogen, it mobilizes the calcium from the bone by activity on the osteoclasts, inhibition activity of the osteoclast, and also inhibitory activity on the promoters of osteoclast, that is inflammatory cytokines, right? So all these points help us in understanding the calcium and phosphate metabolism. Finally, to conclude, we'll try to understand hyperparathyroidism, hypercalcemia. We'll also try to understand how to differentiate it from hypocalcemia or hypoparathyroidism. Then we'll try to understand what is pseudo-hypoparathyroidism. All these points we'll try to understand shortly from now. All right. So what is hypercalcemia? Obviously, the name itself indicates. Now let us try to understand the clinical aspects of calcium metabolism. Hypercalcemia is increase in the calcium, the serum calcium levels. Hypercalcemia as seen in hyperparathyroidism. So what happens is, especially what is known as initiating factor. The initiating factor of primary, the hyper secretion of parathyroid. Say suppose parathyroid adenoma, some parathyroid tumor. All right, 80% of the times it is parathyroid adenoma, which is causing hyper secretion. This hyper secretion of parathormone result in increase in the plasma calcium, decrease in the plasma phosphate, polyuria, hypercalciuria, and decreased bone mass. So increase in the calcium, decrease in the phosphate, it causes polyuria, it causes hypercalciuria, and decrease in the bone mass. Why decrease in the bone mass? Because of increased activity of, am I audible? Increased activity of osteoclasts, is it not? So bone mass is decreased, right? High levels of calcium, they cause polyuria that results in nephrogenic diabetes insipidus. So nephrogenic diabetes insipidus. So what will happen to the volume, plasma volume? Dehydration occurs. So plasma volume deficit occurs. Hence, sudden volume deficit, it's a feature of hypercalcemia. Sudden volume deficit. High calcium, it actually depolarizes the neuronal tissues. So there is depolarization of the neuronal tissues. So patient will develop arrhythmias or seizures. Because of hypercalcemia, depolarization of neural tissues will occur. Because of this, patient will develop coma, confusion, lethargy, constipation. Hypercalcemia is a feature that is seen in men. One, same like insulinoma, parathyroid tumors. All right. It is also a part of men 2A. Men 1 is called as Wermer's syndrome. Men 2A is called as Sippel syndrome. Sippel syndrome. All right. There are certain conditions wherein I already told you there is a peptide which mimics parathormone and starts secreting lot of calcium. We call it parathyroid hormone related peptide. This is exogenous or ectopic parathormone production resulting in malignant hypercalcemia. Most of the patients are asymptomatic here. Unless you find out the cause of depression or fatigue, people will have lethargy, continuous constipation for a very long time, neuromuscular weakness, difficulty in concentration. But only you will understand it, only it comes out when the person develops the primary pathology or malignancy of lung or some tumor of the breast or some other placental abnormalities. At that time you detect that parathormone levels are high, parathormone related peptide levels are high, which were causing hypercalcemia, which was causing all these effects. So any increase in the plasma alkaline phosphatase, you will have to detect it. The serum, the increase in the plasma alkaline phosphatase, the source is very, very important. The liver is the source, lung is the source, bones are the source, skin is the source of alkaline phosphatase. All right, you will have to understand what is the source of alkaline phosphatase for its elevation, and thus you should come to a diagnosis of what is the primary disorder in this patient, whether it is parathormone or parathormone related protein. So here what happens is there is severe dehydration and bone manifestations like osteitis fibrosa cystica. Osteitis fibrosa, bone manifestations like osteitis fibrosa cystica, bone manifestation where what happens is there is increased osteoclast activity. We call it osteitis fibrosa cystica, also known as brown tumor of the bone. So osteitis fibrosa cystica is a characteristic feature of hyperparathyroidism. We have got scalloping effect or demineralization because of increased osteoclast activity, the marrow elements will undergo scalloping and this is replaced by fibrous tissue. So initially what happens, the bone is eaten away, demineralized, the gap is filled by the fibrous tissue. So if say suppose this is the bone which is eaten away, chunk of bone which is eaten away by the osteoclast, this is the gap is filled by the fibrous tissue, osteitis fibrosa, and in the form of cystic degeneration we call it osteitis fibrosa cystica. There is increase in alkaline phosphatase because of high bone turnover here. All right, and we all know the effect of hypercalcemia on the heart. What will happen? Arrhythmias because of increase in the decrease in the QT interval. So hypercalcemia causes QT interval shortening. QT shortening. QT shortening is a feature resulting in arrhythmias, ventricular tachycardia, and patient may die sometimes. All right. So how do you treat this condition? Elevated levels of plasma calcium and parathormone, both are elevated. If suppose calcium is elevated and parathormone, both are elevated, you call it primary hyperparathyroidism. You call it primary hyperparathyroidism. If suppose only plasma calcium levels are elevated, whereas parathormone levels are decreased, so this is not primary hyperthyroidism. The cause is something else like parathyroid related protein, peptide, or some other cause. Say suppose primary hyperparathyroidism, the most common cause is parathyroid adenoma and it has to be removed. And patient has severe dehydration, fluid replacement should be given. Patient can be given a drug called as bisphosphonate. Bisphosphonate. And they are highly effective in controlling this. And we all know that calcitonin, it inhibits the osteoclastic activity. So calcitonin can also be given to the patient pharmacologically. Calcitonin also helps in decreasing the osteoclastic activity and promoting the osteoblastic activity. So this is all about hypercalcemia or hyperparathyroidism, primary hyperparathyroidism. Now let us see exactly opposite, that is hypoparathyroidism. Hypoparathyroidism, the most common cause of hypoparathyroidism is genetic basis, that is hereditary mechanism, seen in families, hereditary. Autoimmune causes are also detected. Autoimmune etiology is also one of the etiologies. Autoimmune etiology is also one of the etiologies. Sometimes it may be iatrogenic, that is, iatrogenic means given by the doctor. So after thyroid surgery, patient may develop hypoparathyroidism because you have removed along with the thyroid gland, you have removed the four parathyroid glands situated in the posterior aspect of the thyroid gland, you have removed it. So because of that, patient develops deficiency of parathormone and thus patient may develop hypocalcemia. So these are all the important causes. Apart from the various other causes, we will try to understand these causes. So before that, let us try to analyze what will happen in hypoparathyroidism. There is decreased plasma calcium, is it not? Hypocalcemia. There is decreased plasma calcium. This decreased plasma calcium is accompanied by increased phosphate levels. It's a very, very important feature. All right. It's a very, very important, because what is the function of parathormone? To increase calcium and decrease phosphate. Exactly opposite happens in hypoparathyroidism. In hypoparathyroidism, even though less phosphate is reabsorbed from the bone, the plasma phosphate levels increase because of normal action of the parathormone, which is to inhibit the phosphate reabsorption. All right. So phosphate reabsorption was increased by parathormone. Parathormone is not available in the kidneys, in the proximal columnar tubule. So in the proximal columnar tubule, more and more the phosphate levels are reabsorbed and patient develops hyperphosphatemia. Therefore, without parathormone, what is happening? More and more amount of phosphate is reabsorbed from the filtered load in the proximal tubule, and that results in hyperphosphatemia. So we'll try to understand what are the symptoms of hypocalcemia. Hypocalcemia causes increased nerve excitability. Increased nerve excitability leads to muscle spasm and tetany. So patient will develop muscle spasm. We call it tetany. Increased muscle spasm. Even to the slightest stimulus, muscle undergoes spasm. All right. When you tap on the facial nerve, just below the ear, there is sudden twitching of the distribution of the facial nerve. So entire face undergoes twitching like this, something like this. This is called as Chvostek sign. So tapping of the facial root of the facial nerve, Chvostek sign. Chvostek sign, we call it. You tie a BP cuff onto the patient's arm and inflate it up to 20 to 40 millimeters of mercury more than the systolic blood pressure, and you remain it like that for a few seconds. The entire arm and hand undergoes spasm. We call it carpopedal spasm. This sign is called as Trocho sign. These are the two important signs of hypocalcemia: Trocho sign and Chvostek sign. A positive response is termed as carpopedal spasm. Trocho's sign and Chvostek sign. So hypomagnesemia, it prevents the parathormone secretion. I already told you, clinically hypomagnesemia, less decrease in the magnesium levels, this inhibits parathormone secretion. This has to be ruled out before declaring it as primary hypoparathyroidism. All right, and immediate infusion of magnesium prevents this. All right. So how to differentiate primary hypothyroidism from pseudo-hypoparathyroidism? Pseudo-hypoparathyroidism is a rare phenomenon. Pseudo-hypoparathyroidism, what happens in pseudo-hypoparathyroidism? Let us see. Pseudo-hypoparathyroidism is a rare phenomenon. Pseudo-hypoparathyroidism has got same signs and symptoms as primary hypoparathyroidism, except that the parathormone levels in the blood are elevated rather than decreased. So we have got low calcium levels, we have got high phosphate levels, but the parathormone levels are high. So why is it high? Because of various genetic mechanisms. We'll try to understand. So actually what happens is there is a resistance to the target tissue. Calcium sensing receptor, I told you there is one calcium sensing receptor which senses calcium, and if calcium levels are low, it causes increase in the secretion of the parathormone. So here there is some genetic disorders of the receptors which cause increase in the very much profound increase in the parathormone, but the calcium levels are simultaneously very low and phosphate levels are very, very high. So patient will have mental retardation, patient will have short stature, the metacarpal or metatarsal is missing, fourth or fifth metacarpal or metatarsal is missing. All right, it's an important phenomenon to be discussed in clinical scenarios. There are certain disorders in which congenital absence of parathyroid gland, we call it DiGeorge syndrome. Congenital absence of parathyroid gland. Congenital absence of parathyroid gland. There is complete absence. We call it DiGeorge syndrome. All right. In case of chronic renal failure, also patient develops hypoparathyroidism and hyperphosphatemia. So hypocalcemia can cause the hypocalcemia may result in tetany, may result in if suppose it is occurring in early age groups, early childhood and all, it may cause congenital, it may be, the cause may be because of congenital absence of the parathyroid gland. We call it DiGeorge syndrome. All right. So these are all the important points about hypercalcemia and hypocalcemia. In our next class, we'll discuss about vitamin D deficiencies, the effect of renal failure causing secondary hyperparathyroidism, vitamin D causing secondary hyperparathyroidism, and excessive vitamin D intake that is causing secondary hypoparathyroidism. We'll discuss all these points in our next class, and we'll also discuss few clinical scenarios like osteoporosis and all right. So thank you very much for patient listening. Any doubt, kindly ask me through email or chat. I'll be happy to respond. Thank you.